NHS and getting outside and clapping them at 8 o'clock. So we're a little bit early. I'd love to introduce you to Professor Matthew Allen, who resides at Cambridge University. And he is going to be talking to us today about something that I'm really, really interested in. We actually do have shockwave at the practice I'm working at. And it's really, really quite an exciting development for managing dog arthritis, fingers crossed. So please tell us a little bit about yourself so that we can get a little bit of an understanding of how you got into this field. And then we're going to crack on.
Okay. All right. Well, thank you for the invitation to be here and join you. So yeah, my background, so I trained at Cambridge a long time ago now, and graduated there and went straight into a PhD, which I did at the hospital, at the Human Hospital in Cambridge, on joint replacements in dogs. I did knee replacement surgery. That's kind of my specialty, clinical interest at this point. So I did that, did my PhD, and then I went to the States in 1995. Went to the States, and I stayed in the States for almost 20 years. Worked for 12 years at a medical school in New York, and then went to the vet school at Ohio State, or the Ohio State, for 6 years, and set up a knee replacement clinical surgery program and ran their surgical research lab. Did a lot of clinical research, including some of the earliest work on platelet-rich plasma in dogs and various other things. And then I got recruited to the vet school in Cambridge in 2014, and I came here, and I have two hats. One is as a clinical commitment is to do total joints, so hip and knee replacement predominantly in dogs. I do that mostly in Cambridge, although I also do that as a wandering surgeon as well. So I'm the global lead for knee replacement for Biometrics, one of the orthopedic companies. So I train people. I'm involved in the training of everybody who does knee replacement surgery. And then back in Cambridge, my other big hat is research hat. So I'm director of clinical research at the vet school in Cambridge. And I have my own surgical discovery center, which is the lab we set up. And our areas of interest include clinical research, including shockwave. We have a fully equipped gait analysis clinic for measuring and recording and capturing how dogs walk and trot. So we can really describe lameness better than just, it's off or it's not. So we can actually really get down and get quite detailed about it. And that helps us when we want to look at how dogs are doing after treatment. I have other areas of interest, including bone cancer in dogs and in children, and all sorts of things in technology, ranging from new biomaterials for surgery, the use of 3D printing guides, and also robots and surgical navigation. So really broad stuff. Basically,
everybody's leaving now because we've all got mental health problems because we can't keep up.
Yeah, no, don't worry about that. It's basically like a little playground. I get to do usually really fun stuff. It's not always easy. It's usually fun, and I work with a great team of people. So are we
going to be able to get you back to talk about hip and knee replacements?
Yes, yeah. Well, I'd be happy to talk to you about that at some point in the later on, for sure.
Amazing, because that comes up a lot. Okay, so let's crack on with shockwave. I think for me, I need the cam followers to kind of understand about the disease so that they can understand the intervention. So just do a run through about OA so people are in the position to take it further.
Yeah. Okay. So there's a lot of parallels between the arthritis we see in dogs and cats and horses and what we see in people in terms of how the patients present. So soreness, stiffness, lameness, discomfort. There are some big differences between the sorts of arthritis we see in dogs and cats and horses versus people, though, because most of the cases of arthritis in people are due to basically age-related disease. They're degenerative type conditions. They happen later in life. It's an old age disease, not always, but predominantly. And in dogs and cats, most of the disease we see is actually not from old age. Maybe in cats there's an element of that, but mostly what we're seeing is the consequences of other diseases in the knees or the hips. For example, dysplasia, so this inbuilt failure of the hip to be normal. Or another common one is the ligament in the knee, the so-called cruciate ligament, which will fail, and you'll see arthritis after that. Or elbow disease, which again is a congenital disease where they're born with this genetically linked disease. So a lot of the disease we see is secondary to trauma. The end result, though, is very consistent across species, though, and that is an uncomfortable joint with a varying degree of inflammation, So lots of swelling. It may be evident as fluid. It may actually be swollen and fluid filled, but often it's not. Often it's just inflamed at a tissue level, and it's uncomfortable. And as that discomfort progresses, patients, whether they're human or animal, become less able to do their activities of daily living. So they become more sedentary, and they can put on weight. They can get secondary other diseases from that, and they become less good companions for us. And we imagine them to be less comfortable and less happy with their quality of life. So it's a really broad-reaching, impactful disease, massively common and wildly underdiagnosed. We'll see, you walk around any street on any given day, and you'll see dogs walking around that are sore, stiff, may not even be diagnosed, they may not be treated, but there's an undercurrent of disease that really has a huge impact on the quality of life of our pet patients. And that feeds into the impact on the owners, because the dogs don't want to go out. The owners don't get out. Right now, we're seeing everybody and their brother is going out for they're going out on marathon runs right now because it's the only time to get out of the house. The poor dogs and cats of Britain are getting exercise at levels they've never seen. But with you have an arthritic dog, as I do, you do have to manage that carefully. So it has broad-reaching implications. The disease itself is quite variable in what's going on at a very simple level. Essentially, the normal pathways by which the joint, and we've always thought of the joint as being two bones joined together with some tissue around it. And now we understand a lot more. The joint is an organ, just like a kidney, and it has multiple components. It has the bones, sure. It has the cartilage, the smooth, glistening bit on the end that allows you to move very at low friction. It's a very easy moving, nice, smooth joint surface. It has the tissue around it, which feeds the cartilage. The cartilage has no blood supply. So it relies on the fluid inside the joint to bathe and immerse it and provide the nutrition, the oxygen and the biochemical nutrients the joint needs. When you get inflammation, all of these things, this normal balance, this healthy balance of this almost ecosystem gets entirely disrupted. And when that happens, bad things happen, including the death of the cells that make the cartilage. So the actual cartilage itself starts to die back, and that will eventually be lost, rather like a lining, it gets rubbed off. The tissues inside the joint are inflamed and painful. The pain receptors inside the joint are activated and they're painful. And so you have this chronic, long-term now condition where this degeneration, this collapse, this failure and breakdown of these tissues leads to a joint that no longer functions normally. So it's very early on, it's just painful, but eventually it stops being efficient as a machine, as a moving thing. The cartilage falls off, and eventually you'll grind through the cartilage down onto bone on bone. And that's usually in humans the point at which the patients cannot tolerate. They'll get pain at night and they can't tolerate it. And that's when they go to the doctors and ask for a knee replacement or a hip replacement. So it's a really multifaceted disease. The good news is there's lots of potential intervention steps that you can take, including some of the very common old-fashioned things, which actually work really well, like reducing the load, reducing the weight put through the joint is a very simple and very effective thing. So thinking about weight management, thinking about how much work the joint does. So thinking about exercise, not restriction, but control. So lots of simple things you could do.
I think that's a brilliant point. I just want to highlight what you said and how important it is. I did a lecture about a year ago, and I referred to the human NICE guidelines and about how controlling your activity, considering your activity, weight control, adapting your lifestyle, using heat therapy, manual therapies was really, really important to initiate early. And on their guidelines, very low down, was starting to use non-steroidals and anti-inflammatories. And this guy put his hand up and went, well, we don't see those patients. So we see the dogs that need it. And that's exactly what you've just said, is that all of us, a joint team of both owner and vet, need to be identifying these cases earlier so that we have more options. And these, as you say, foundational and sometimes forgotten interventions like weight control, lifestyle change, game changers.
Absolutely.
Love it.
If deployed at the right time. Absolutely. And I think there's a few elements of that need to be taken into account. One of them is we do a very poor job at recognizing and measuring how much a dog or an animal is affected by this disease. That's difficult. As you say, as the vets will say, they can only measure things if they come into the consulting room. We can only treat what we can see. So there is a relative lack of recognition of the problem. When we get them, from a convenience perspective as practitioners, no matter how well intentioned, sometimes you end up just treating because that's how you treat them. The standard, the owner expectation is just give me some tablets and make this go away. But actually, it's the last thing we should be doing. And you're exactly right. Because we're not seeing cases at their earliest, a lot of these really pivotal interventions we could use that are very safe can be highly effective. The study, there's a very good study out of Purina, out of University of Pennsylvania with Gail Smith, looking at the impact of simple weight control on OA symptomology. So how affected dogs were by the symptoms of OA. And just a simple weight control program is an absolute game changer if employed from the start. The problem is, at some point, the damage becomes bad enough that it becomes a mechanical issue. And that's how I always try and approach this with owners, is there's a point where it's just biology and there's an enormous amount we can do. There's a point when it becomes almost purely mechanical and the horse is bolted, and then that's when we go to surgery often. That's a really, and we've got to do better. The whole concept of regenerative medicine is only going to work if we get those animals at the right time before the mechanics has gone wrong. If I get a joint, and I've had dogs referred to me for knee replacement surgery and being told, well, it had stem cell injection. It had 1 million stem cells put in to its knee a year ago, and it hasn't worked. And so stem cells are therefore bad or useless. The reality is, if you look inside that joint at the time that those cells were put in, there was almost no cartilage left. No therapy in the world that's cell-based is going to do that. Unless stem cells are equipped with crampons and oxygen supplies, there's no way they can cling to a knee joint and live and survive and thrive. That's when you need surgery. What we've got to do is move way forward to a point where we can intervene with both behavioral and biological change to get maximum effect. Only then will we really be able to test what's effective and what's not.
And I think for that to happen, and I kind of get goosebumps because I can see the future and how different it could be. We have to get owners willing to hear things that they don't want to hear. And from a first opinion perspective, so a vet behind a first opinion table, when you say to an owner that's only just started seeing subtle signs that there is actually quite a big problem, bubbling away, they don't want to hear that. And that's something else that we need to try and address, in my mind, is that if we can raise awareness about the disease, if we can make everybody realise that it's a common problem that we need to attend to early, hopefully we can change that hesitancy to engage. Anyway, that's another story. Let's talk about your work with Shockwave, because I find this quite exciting, really. The reason that I find it exciting is it's possible, it's achievable, it's attainable. That's what I'm trying to say. That is equipment that can potentially find its way into first opinion practice. So that's why I was really keen to talk to you. So tell us about Shockwave, blah, 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 and I'll keep
Okay, sure. So Shockwave is, like you, I'm relatively new to Shockwave. I came across Shockwave really just coincidentally, and we were fortunate very early on. We partnered with a company called Storz to get into this, and I was put in contact with an excellent, actually, I think Kiki Hauser from Stuttgart was has done one of your Facebook lives, I think, at one point. And
no,
Kiki,
she hasn't yet.
Oh, she hasn't done it yet. Oh, I thought she'd done it.
No.
Oh, you need to badger her. All right,
to.
Kiki, you're on warning. You're on notice. Well, Kiki is an expert. She's a rehab specialist from Stuttgart in Germany, and is an expert on the use of shockwaves. Done it for years, and sort of under the radar a little bit. And we were able to partner with her, and actually then with Storz do some work on that. And so we've come into, what I like about it is the fact that, as you say, it is equipment that is not broadly available, but it is available. It's affordable in a private practice setting, not just a specialist practice setting. The other things I really like about it are it's not a toxic treatment. There's no pills being popped. There's no chemicals going in the system. And if it doesn't work, you stop. There's no long-lasting ill effect. So it's very what we call low invasive and low risk. And so I really like it for that reason. So that's a good reason to start looking at it. But what we found is that actually it can be very, very effective in managing some of these dogs. Again, rather like pills, not every dog. And a lot of our future focus is going to be trying to understand what characteristics of a dog and a particular dog at a particular stage of disease makes it a good versus a bad candidate. Because much as cancer therapy has gone, what we're going to see is an evolution. The thing I'm excited about is personalization of veterinary care. So we will not just assume that Millie the dog, because it's 8 and has osteoarthritis, is going to get tablets in the box marked 2. We're going to give Millie what Millie needs based on information that maybe at the moment we don't have or we don't recognize. So that's what we're going to focus on. With shockwave, shockwave is not a new therapy. It came out of Germany originally, working on the use of sound waves to destroy kidney stones, actually. And so kidney stones, when they form, they use a thing called lithotripsy, which is basically high energy sound waves are fired into the patient from outside or from inside, depending on the technique. And they actually blast into these solid deposits of material that form the kidney stones and destroy them. And coincidental with that, they were looking at some studies of patients who'd had that done. And what they found was that in some of these patients, there were some interesting changes in the bone that was adjacent to where the kidneys are. And they recognized that this might be associated with these sound waves that they've been firing in. And from that sprang this idea that shockwave can have an effect on tissues, not just a destructive effect, but actually a reparative effect, because these bones were showing signs of building new bone, of getting stronger and of repairing. And so skip forward then a number of years, and now you've got a number of manufacturers, predominantly human, but some veterinary market. For these instruments, there are different sorts of instruments. There's different terminology. So there's, depending on what you read, people will talk about low energy shockwave and high energy shockwave. But in principle, the high energy shockwave, which is the predominant one that is medically beneficial, is essentially a sound wave. The way it's generated varies, but essentially it's a sound wave that travels at the speed of sound through the tissue. And when it hits the target, essentially it blasts. It creates a sonic boom at a tissue level. And far from being disruptive, if you get the settings on the system correct, far from being disruptive and destructive, that cavitation, as we would call it, that opening up of cells, the stretching of cells, turns out to be very beneficial. And it can be beneficial because through mechanisms that we don't fully understand, we know that it will enhance healing. We know it will decrease inflammation. We know it will decrease pain. And if you think about osteoarthritis and what I talked about earlier in terms of the symptoms, pain, degeneration and damage to the tissue, inflammation, those are all the hallmarks of what we're talking about. So we have in this box an opportunity to, without taking anything into the animal's body or putting it in or opening the joint up, to go in and disrupt these pathways that we know are deranged in arthritis. So that's what we've been looking at. And so there's very little. If you do a search on the literature for veterinary applications, there's very few. But we've been fortunate we can work with some through Storts with medics who do this. And there's actually a pretty rich history now of shockwave being used. It started off being used mostly in soft tissue injuries. So it was predominantly in things like frozen shoulders and tennis elbows, plantar fasciitis, so the sort of disease of the foot that people get that's extremely painful. Those all turn out to be quite responsive. Arthritis is relatively more recent, but there's some really good now data. So, you start off with these things with an individual paper. Somebody writes up a paper about 10 patients, and then somebody does a big study, and then there's another study, and eventually the amount of evidence builds. And in human medicine, when the evidence really builds up, they have what they call a systematic review, which is a review of a whole bunch of papers. And the most recent data on that demonstrates very clearly that shockwave therapy, for example, in knee arthritis in people, is extremely effective at reducing pain, improving mobility of the joint and increasing functionality in terms of quality of life. And we have measurement systems in human medicine for measuring how well you're doing as a quality of life measure. So those are all improved by shockwave.
I'm just going to butt in. Yeah. I'm just going to butt in. Kiki says hello.
Oh, Kiki, hi, Kiki.
She's just shouted at you, non-unions, exclamation mark.
Yeah, I'll talk about non-unions. Yeah, so in essence, she should be sitting on my shoulder, parroting me. So in essence, it has a number of applications, including, as Kirsten says, we've had really good luck with looking at it. It's in humans, non-union. So when fractures fail to heal, if you do that in humans, 70% of patients who have what medics describe as non-healable fractures, 70% of them after a shockwave treatment will actually go on to heal. So it has very, very intriguing prospects. It also, going a little bit beyond arthritis, has enormous potential as a way of stimulating the normal repair process in the body, which of course with regenerative medicine coming along may be an absolute game changer. So this idea now of, Kirsten will talk about the importance of a lot of us recognize the value in prehabilitation. So in other words, instead of thinking about rehab after surgery, what about doing something before surgery to condition the joint, the tissues around the joint, the soft tissues, the fascia, the connective tissue, all of that. And if you do that with regenerative medicine, there could be a real opportunity there. So
yeah, I was fascinated about the work that they were doing on patella desmitis.
Yes. Yeah.
And there's a real tendency for us to use one intervention when managing a case. You're either surgical or you're regenerative or you're shockwave. But the idea of using different interventions at one point is really, really exciting. It's like really exciting.
Yeah, absolutely.
Whether it's because people are only specialists in their field or whether it's a price point thing or an availability thing. But yeah, absolutely. So just tell people a little bit more about this sound wave and the cell thing. I think what I'm trying to dig into is that a lot of CAM followers will imagine arthritis as gnarly joints that are just rubbing against each other, and that's where the pain must be coming from. They feel it's a very physical, mechanical disease like you described, but that's quite end stage. I think there, and from my own learning, I don't think I came out of university equipped to understand about the inflammatory processes and the nerve sensitization. And that's where the pain is coming from and how we can use the body's own chemicals to dole it all down again. But there's that mindset that they can only see mechanically. Kind of explain the soup.
Yeah, so that's an important point. It isn't just, although, as you say at the end, when all things have fallen apart, it is a gnarly, disrupted, mechanically incompetent joint. Way before that, there are changes that involve pain and sensitization to pain. And I don't mean sensitized as in, oh, my dog is a bit sensitive. I mean true sensitization. In other words, a dog that is genuinely overly responsive to pain. There's very good evidence for this in humans and in animals that patients can become, especially when it's chronic, can become very sensitive to even low-level amounts of inflammation, that those can trigger, if you like, an extraordinary response. So they're genuinely uncomfortable. Often find that with arthritis patients, people go, oh, he's a bit stiff, but he's not painful. And I struggle with that as a notion, because when dogs and animals are reluctant to move around, unless the bone is literally out of place, there's a reason, and it will at its seat be pain. Now, you can argue about how we measure that, but I think that that's a given. These animals are painful, and they therefore require, I think, some sort of intervention. But that doesn't always mean surgery. In fact, most of the time, I would argue it doesn't mean surgery. It just means being really tactical. So the pain, what we know about pain and shockwave is that there are two primary mechanisms by which shockwave affects pain. One is a very sort of blunt instrument. It's almost like a carpet bombing approach. When you fire shockwaves, you're firing these hypersonic waves going through the skin into this tissue. We can target them really precisely to within a few millimeters using the technology. So we know where it's going, and we bombard the tissues and it actually dulls their sensitization. It dulls their ability to respond to pain. Interestingly, the process when we do that isn't itself painful. One of the first questions I always get about shockwave with patients is, oh, well, do you have to anesthetize the patient because it must be painful? Because I've heard it's painful as a human when you have it. We use a different sort of shockwave, and we've never yet had to, except for the animals that have fractures, we've never had to even give sedation to a dog. We've had dogs falling asleep. So are you using radial
then? Are you using radial?
No, we're using focus shockwave, and that's a big difference. It's a huge, huge potential advantage of focus shockwave. All the data shows that the mechanisms at a cell level, there's very little difference between radial and focus shockwave. And yet, the way you deliver it, because of the energy level, we can use quite targeted, lower doses of focused that are not painful to our patients, such that we don't need to sedate. I'm not saying there aren't cases that might need to be if they're fractious, but pain does not seem to be something that we recognize. So the first thing is this big gun approach. Blast them with shockwave, and the nerves almost go into paralysis and are dulled. The other thing is really exciting, and that is some data that suggests that there's a very specific chemical that's released that's associated with, it's a natural, almost like an endorphin, but it's a natural pain reliever called substance P. And there's some pretty good data, at least experimentally, that if you use shockwave, you actually release substance P. And so it actually, the body in a sense self-soothes. So there's a lot more to be worked out. And what we don't know is the most appropriate dose, delivery method. Again, this, as you pointed out, these two almost camps of thought. One is radial shockwave and one is focused. And they're really in how the shockwaves are generated and how they're delivered. But there's, rather like there's all sorts of different sorts of arthritis, there are all sorts of different sorts of shockwave, and we have to be very careful about describing what we're talking about. So all shockwave really is not the same. Yeah,
it's a bit like laser, guys. So laser world's going crazy as well, and there's a lot of manufacturers of different lasers, and they're using different protocols, and it's skewing people's understanding, and it messes with evidence and results and getting like answers, because people are doing it differently and you can't lump them all together. I've been looking through some shockwave stuff. I'm not near you at all, but I have got to write a practice handout soon, so you can help me. But yeah, I was reading through, and there's some real positive for both radial and focused. Just out of interest, I just want to rewind a little bit. We have been sedating because the machine is just so loud, and it's really quite invasive. So we've put them under a light sedation, and they're normally, geez, you know, and almost throwing themselves off the table. Do you not have that problem?
Nope. No, it's a background click. It's very similar sort of clicking sound you get to a bug zapper. It's a background click, like the click you get on an old-fashioned gas stove when you press the button and ignite it. You get that click, click, click. It's very quiet. We've had zero issues. We've had dogs fall asleep on the treatment bed while we've been treating it. When I first saw it with Kirsten, I was absolutely sure she was sedating dogs in the back and then bringing them through as a compliant dog. But in fact, no, it's really amazing to see.
Okay, so Cam Fullers, correct me if I'm wrong, because I probably will be. So we've got radial shockwave, we've got focus shockwave, and then focus shockwave breaks down to 3 different generators of the shock.
Correct.
So then you've got your electromagnetic, electrohydraulic, and your piezoelectric. So what are you using? Because we're using electrohydraulic, which is quite loud. What are you using?
I have to get this right. We're using a store. So the system you're using, if you're using electrohydraulic, then what you're doing with an electrohydraulic is, in essence, you're creating a spark underwater, and it is quite loud. We use an electromagnetic system. An electromagnetic system is I mean, it's all in the detail, and I'm not an engineer, but in essence, it is a piece of metal that oscillates with a magnetic field. And because of that oscillation, when that metal plate hits, it generates a sound wave that then is focused rather like a loudspeaker out into the patient. So there are differences in how these things are generated that explain why they sound different, why maybe they're priced differently. But actually, if you look at the data on the nature of the shockwave, most of the ones that generate the shockwaves that, as you talked about, the focus shockwaves, electromagnetic, electrohydraulic, or piezoelectric, functionally, what comes out, no matter how it's produced, is pretty similar. Whereas the big difference is in the radial shockwave is really not shockwave in the sense it's not a sound wave. It's generated by percussion. It's basically, if you imagine a jackhammer, if you jackhammer on the tissue, you create a wave inside the tissue, a response. That is so actually it's not a sound wave, and it's certainly not a supersonic wave. So it's still called shockwave.
It can only go a certain depth, can't it?
A limited depth. The big advantage of the radial is you can do area coverage. You can do broad coverage. So if you think about this in terms of muscle, for example, if you have tightness in the connective tissue over the muscle, the fascia, then doing radial treatment broadly could make sense. It's quite superficial, quite close to the skin, not too deep, and very broad coverage. Versus if I want to get inside a joint, and particularly I want to target the joint, parts of the joint, I want to be able to focus my energy, which is where the focus comes into its own.
Yeah. So cam fullers, just so you understand what that means, is that certain handle pieces that you use, so say I was shock waving my elbow, some handle pieces, they spread the energy and it goes out, and some handle pieces come and bring it in. And what we're talking about is radial spreads it out, whereas focuses it in. So you've been doing, let's bring this back to reality for people. And I think the people that are going to love this the most are the ones that are working with elbows. Probably the hardest joint to manage, would you say?
Yep. I think that's the one. The most frustrating. Well, for a variety of reasons. Firstly, extremely common. I think what we also see is that if you were to sort of rank the degree of disability for a dog, that elbow disease is often the most impactful on the dog. When you see a dog with bad elbows, if they had equivalently bad knees, I'm not sure they're as affected clinically. These dogs look grim, and eventually they'll be doing the short, choppy stance, so they could be very affected. Losing movement in your elbow joint is extremely disabling, because the only way to do it is either to shorten your stride or to bring your leg right round and go round the arc. And we know that from when we fuse and when we lock those joints together at surgery, if we have to basically stabilize the joint, we know that fusing the elbow is really bad for the dog. So I agree with you. The other thing is, unlike hip dysplasia, where it's pretty well understood, we have elbow disease, and it's a big bag of problems. Lots of different things it could be. Lots of different, what we call pathophysiology, so pathways through which disease becomes evident. Lots of ways of things being damaged. Lots of different bones affected in different ways. And it's extremely difficult to unpick these cases. We often see 3, 4, 5-year-old dogs with elbow disease. They actually have had elbow disease from birth. We just weren't smart enough to recognize it, or we didn't see the dog early enough to really intervene.
Dwell here for me. Dwell here. Okay. This is something that I really want owners to hear. I did a consult once, and it will always haunt me. And it was a puppy. It was about 14, 16 weeks, something like that. And the puppy was hesitant about the examination and doing flexion and extension through, I think it was the elbows or the hips, I can't remember. And I introduced the idea as something that we needed to watch. It was something that we needed to keep an eye on. And oh my God, I wish, I didn't want to be in the room with that person, because I can understand the disappointment that came out in her, and it came out quite violently. And how dare I say there was anything wrong with her puppy. I just want people to get a little bit of reality of what it's like to be on the other side of the table, being that person that is identifying the disease. And it's very, very difficult when somebody has no awareness that there was anything wrong, and you as the clinician says, there's something not right. So I think we need to embrace that these health checks, these examinations, owners are very focused on the heart check, and they're very focused on the abdominal check. And if anybody said that doesn't sound right, there's something not right with that heart. I don't like the sound of it. They'd embrace that and go, right, what are we going to do about it? But there seems to be a little bit of difficulty when I say that elbow's not got the full range of motion. There's hesitancy. I think there's a little bit of discomfort there. There's almost like I'm not going there.
Yeah.
Is that...
Well, yeah. No, I think that's true. And what I would say is, I think that we need to move away from this idea as the vets, almost as the police. We're not there to cause problems. The reason we bring that up and put a watch on it is because what we want to do is follow that and understand the right time to intervene, which is usually, as you say, not at that point. But for us to do our job the best, we need to see those animals early on, and we need to see them at the right time. So when we want to do intervention, we're not coming to it too late. So if we come to the end of if everything I see has an end stage joint because it's all gone to pot, then surgery is the answer. And that's not because I want to do surgery. I love doing surgery, but actually I would far rather manage these all non-surgically if we could. To do that is a partnership. We have to get buy-in from owners to understand that when we say there's an issue here, we're not judging. We're not saying it's a bad puppy, it's a good puppy, it's a bad choice, it's a good choice. We're just identifying something to watch, because if we watch it, and particularly if through the sorts of things we're doing and others are doing with shockwave and new drugs and biologics, in 10 years' time, my hope is that we have the ability to have almost on the wall a chart that would allow me to identify where your puppy is, your dog is, and say, right, this is where you are, and unchecked, this is where we're going. But these are the steps to do now, and to adjust that. So we do very low level intervention, behavioral, weight management, exercise control, see where that goes. And then we do nutraceuticals. And then we might think about a biological regenerative therapy, and we might think about shockwave. And only when those are done do we then medicate. And only when the medication fails do we go to surgery. There are obviously situations where surgery is indicated, where things fracture or things fall off. But generally speaking, we need to move to a much more holistic approach where we actually understand where your pet is on that journey, and we do the least invasive step that we can to change that pathway down back towards health. You can have dogs. We've all had dogs and cats that have had arthritis that have got by. But we can do better than getting by. Having arthritis is not a step away from saying you're going to need surgery. I spend much more time telling people not to have surgery than to have surgery, because I think the outcomes will be much better. Apart from anything else, you don't have to recover from surgery. And
it isn't. I think there's a little bit of a tendency for people to think it's a fallback plan. Surgery, and I know you're a surgeon, don't want to be rude, it's not 100%. We have cases that fail. We have that do suboptimal. We, think, it's okay, I can fall back on a hip replacement. You
have cases that fail, really? Surgeries that fail? I can't believe it. I can't believe that. I can't believe there's a surgery that hasn't worked. No, never. No, absolutely right. And they fail for the same reasons as medicines fail. Most often because we don't understand enough about the patient we're dealing with to pick the right procedure. Sometimes because bad things happen to good people and good animals, bad luck comes along. Dogs doing great over exercises breaks down the repair. But if we could avoid that, if we could be much more measured, but in order to do that, a whole bunch of people are going to have to get a lot of research done. And that's probably the focus area that the clinical research side of our lab really tries to do. We now do the surgeries we do in the vet school are very similar to the specialist surgeries that a lot of people do. So that's not novel. What's novel, I think, is our ability to look and document cases and follow them up. What we need to focus on within vet schools is doing the best possible research to try and understand, to get enough information, in a sense, to populate this picture so that we can then give that back to general practitioners and say, right, this is where you are on that journey. If you get to here, that's a call to us. But these can all be managed with you. And we need to do these more structured.
I do think as well, as you say, two things out of that. Firstly, the centres that can offer more than one modality should be using it as a multidisciplinary team. So you know, if you are in a referral centre where you've got the surgeon and you've got the rehab team, and you work together on a case and try the less interventional before you end up doing surgery, I think that would be one thing I'd think about. And the other thing that I was thinking about, it's actually gone out of my head. It's really important. Oh well, it'll come back. I'll shockwave my head.
It'll come back.
Talk about the elbows more, okay? Because I know that from Holly's Army, elbows are mentioned a lot. So I don't know if you know about Holly's Army. It's our little community group. It's not so little anymore. There's nearly 4,000 owners that support each other, which is beautiful. It is manned by professionals. So we have professionals overseeing it. So there's no hit and run advice is allowed. No marketing is allowed. So no companies think you can get in there and start just swaying people's opinions with your fabricated stories. It's a safe place. And the owners look after each other, but elbows feature a lot. So tell us what you've been finding with your work on elbows.
Okay, so I mean, we picked elbows. The study we're doing, or about to, I think, really, we've done some preliminary work, and we're going to, I think, in fairly short order, once we get back from COVID, enact a clinical trial. We're going to have a multi-center clinical trial. It's going to be at least 2 or 3 centers in the UK. Vienna, Stuttgart, and I think Frankfurt as well. Multi-center clinical trial looking at the effects of shockwave therapy on elbow osteoarthritis. The reason we picked it is for exactly the reason you said. It is one of the most clinically problematic joints we deal with. And this is especially true, unlike the hip or the knee, where when it gets really bad, we can put a new joint in, we can replace the joint with pretty good success rate. The success rates with elbow replacement are not great. So we don't have a lot of options. And that, I think, is why it's scary as an owner to see dogs with elbow disease, because we can't offer a lot of guarantees. No. That also makes it very rich as a ground for trying to do better, frankly. So what we're trying to do is use shockwave to improve, essentially, tissue within the elbow, to decrease pain, to decrease lameness, which is a reflector of pain, but it's a good and easy, objective, measurable thing. When we measure lameness, we're not doing it by me looking at the dog and saying, oh, yeah, it's lame. We put it over a computer-based system. We get absolute numbers. We have a treadmill. Others have different systems. But there's very sophisticated ways to do it now so we can follow dogs. And again, what we want to do is have enough information, not just to say, well, this works in 60% of dogs. I'm sure it'll be fine. Owners don't, and patients don't. 60% doesn't mean anything, because you're an N of 1. You either respond or you don't. Your dog responds or it doesn't. We need to understand on an individual basis what's going on. So we need to treat, and then we need to follow up, and we need to see if that treatment's not working. We need to be brave enough to say it's not working, and wise enough to pick a good alternative and try that. With shockwave,
What about studies that have been done with OA? Because there's been a few that have been done in hips.
Yeah, there's been a couple of studies on hips, mostly I think radial. There's been no study on elbows. There's been a study on stifles, and there's been one on shoulders done by Mike Kowaleski from Tufts on shoulders, but 2 on hips. One, I think Barbara Bocksteller did out of Vienna, did a study. The results with those, and I'll preface this, one of the problems we have with shockwave, which is true for all veterinary literature, is often we're dealing with very small numbers of patients. Yeah. And one of the things we know from human data is when you look at the systematic review I told you about, a systematic review of human knee arthritis and shockwave, that is based on 4,580 patients. Across multiple studies. I think, multiple, like 80 studies or something. And we have nothing like that. So this is where our evidence base is missing. It makes me reluctant to promise anything, except that we're going to try and come up with a solution. But nothing on the elbow yet, interestingly, despite the fact it's so prevalent. I think part of the reason for that is that it is very diverse. There's a lot of potential reasons. Not all elbows are the same. With a hip, it's usually one cause. With a knee, it's usually a cruciate. So we've got a better handle there, a little bit more similar, those cases, than they are dissimilar. With elbows, it's quite difficult. We're doing our study. and we're doing it because it's going to be clinically impactful, we accept up front that it will be much more difficult to get a result that we can interpret. And that's why it's multi-center, because we're going to need to get cases involved. And of course, this is a great opportunity for your network to be involved. And as we will send you the information on the trial. There'll be some advantages to the trial in terms of costs and access. There'll be a few centers in the UK where we can do this, and the same in Europe. But that would be a great opportunity to contribute and hopefully benefit from this research. It is, I mean, that's one of the things we can do as researchers. We can give the owner something.
Give the camp followers a bit of an understanding of the commitment. So generally, it's either 1 to 3 or 4 treatments. Some studies are doing a treatment a week apart. Some studies are doing a treatment and then 3 to 4 weeks later, they'll do the next one. So again, there's a lot of variation there, guys. But what's really exciting about this is it's almost as simple as having a Cartrophen injection, which is just standard around the UK, of taking your dog in, having an injection once a week for 4 weeks. You can do it 3 times a year. Bob's your uncle. It's obviously not the same price point. I get that. But that idea that you can say to yourself, right, I can see the first signs that we're losing control of pain and function. I know that this was very effective for my dog last time. I'd like to explore it again. I think in a couple of studies, some people were saying it was functional, it was offering benefit for up to a year, that some of these dogs had improvements for. So we're talking about an outlay of money that's giving a pretty good duration of action as well, which that again excites me. So we've had a couple of people that have already said, how can I find out more about this study after COVID? What are the candidate inclusion criteria for the elbow study? Guys, I will promise you, I will stay in touch with anything that I can to help you, find out where these studies are happening if you want to be part of them. Take it a little bit further. Let's talk about soft tissue, because I think I've learned a lot in the last few years regarding the fact that dysfunctional joints create other problems too. So we're talking about the elbow. Quite often we have shoulder tendinopathies, etc. And then, as you say, post-cruciate surgery that leads to OA, it hopefully slows and it can influence, but you're still going to get OA there. The fact that shockwaves influence the patellar ligament. There's other uses in our big umbrella that CAM tries to help manage. Are you doing anything with that, the tendinopathies and stuff like that?
We have done a couple of cases of patellar tendinopathy in large dogs with post TPLO. I have to be honest, we haven't got enough numbers to say if it's valuable at this point. We didn't have particularly good responses in either of those dogs. But I'm not going to make any judgments because it's just too small of a series. Kiki probably would be the person to talk to you. In fact, you should have a session on soft tissue.
Nominated
again. But there are obviously some pathologies. For example, with a cruciate, you'll get changes around the inside of the knee, the so-called buttress. Those changes are very directly related to the disease. Other times it's more an issue of reduced mobility and in the sense that the muscles and the connective tissue around the sleeves of tissue just not being as flexible. So again, rehab, whether it involves shockwave therapy or passive range of motion, hydrotherapy, all of those ancillary things all have a role. So it comes back to what you said, which is as we move forward, we're going to need to get much, much better about being multimodal at the level of the clinic. I don't mean sequentially multimodal, as in, we'll try this. If that doesn't work, I'll give it some tablets and then I'll do surgery. Actually, in terms of, right, we're going to do, for example, shockwave therapy, but why don't we start with giving, is the dog on nutraceuticals? Is the dog on joint supplementation, visco supplementation? What else can we do to try and figure these things together? Working with pain specialists rather than thinking that we know everything about it. I know what I know, but I probably don't know very much about what I don't know. Lots and lots and lots is the answer. And so it's really good if you can be within a setup where you can reach out. So people, one of the great things about my relationship with Kirsten has been the fact that I don't have to try and pretend to know anything. Unfortunately, today I've ended up being the one doing the talk about shockwave, whereas she's in fact the expert. I can talk about it from my perspective as a user of it and as a researcher in it. But in terms of practice, That's her domain. And we need to be much better about recognizing the value of these veterinary professionals in doing things that we don't do. Just because I don't know about it, and it's maybe not as glamorous as fixing a cruise ship, doesn't mean it's not impactful. In fact, arguably, it may be a far greater contribution in the big scheme of things. Because I think as regenerative medicine kicks in, there's going to be a massive shift in the way we think of things. The other thing I want to talk about is insurance. It's very important to get data, because we can start to talk about value. And insurance companies are increasingly looking at value. They want to know what we're doing. So one of our aspirations is to really demonstrate value. Shockwave is not inherently expensive to deliver. If we do it as a clinical trial, it'll be much less expensive even than the regular clinic rates. But compared to doing a stem cell injection or an injection of platelet rich, it's really quite cheap. I mean, the course of Shockwave we offer clinically is 6 treatments at weekly intervals. It could be less probably, but we started off doing 6 because that was a good number that Kirsten had experience with. It's 6 weekly treatments. And then usually we see a response. It usually is about 4 weeks after we finish that we start to see a really significant response. And then we do see that to be sustainable. And we've certainly seen value out to 6 months. I'm not going to say 12 months at this point, but here's the beauty of it. There's no reason to believe that if the dog responds well to one set of runs, that it won't respond well to a second set. So when it runs out, we just redo it. And because it's not invasive.
Second set, you might only need to do it twice.
May need three to trigger it and knock it back down, because what we're doing here is we're, as you talked about earlier about this super stuff inside the joint, we're trying to get that joint environment away from being inflamed and angry towards being more quiescent. As the dog starts to feel more comfortable and starts to exercise in a more appropriate manner, and the flexibility returns to that joint, the whole biological environment changes as well. The tissues are healthier. There's more blood supply. So the waste materials are drained away better. The tissue can just dramatically improve. Now, if you go to surgery eventually, that's still beneficial because it means we're dealing with healthier joints. But hopefully we can even avoid surgery at all. Yeah. And then we'll be really making an impact.
Yeah, no, I think that's really important. I know what the point was that I forgot earlier. I do think that first opinion practices can contribute to this. So we were talking about referral centres offering a true multidisciplinary approach and having the different disciplines actually working on the same case, so that they do have an array of interventions. You don't just go there and the only option is surgery, or you don't just go there and the only option is pharmaceutical pain management. But I do think that first opinion, you know, if this is interesting you, get in touch with your local referral centres and just say, you know, I'm really interested in this. I really want to start building up a caseload. I want to, you know, network, because this is needed. We were talking earlier before we went live about how neither of us understand why this disease doesn't get a lot more attention, because it's so exciting. There's so much to learn. There's so many interventions that are possible. You know, it's not many diseases that you get to have so many different therapeutic potential interventions. It's crazy. So yeah, first opinion vets, if this is quite exciting to you, don't hesitate to become part of the bigger plan. The other thing that I wanted to talk about was, wouldn't it be powerful in a waiting room if we could have a video where a young dog goes through like a crystal ball and it comes out as an older lame dog, and people could actually connect that early management changes will have massive impact later in life. And that's a big disconnect at the moment, that you've got this young, bright, amazing dog that's mildly limping. If we don't intervene, is going to rapidly progress beyond its years, and that needs to be illustrated more. So any pharmaceutical companies, supplement companies, or anybody that wants to get in on this, then get in touch. Amazing. You didn't get forewarned about the 10 top tips. Sorry. So
no, I didn't. Okay. Super. So, 10 top tips. So off the top of my very bald head.
Off the top of your very bald head, we'll share it with 5 each, okay? So you're going to start. I'm going to start with number 10, because then you number one, which has
are these being assigned a value based on order? So is the number one tip the most important, or are we just spouting these off the top of it? Okay,
just
all right.
as you go. But what it has to do is it has to be relevant to all followers. Okay, so you need to consider all financial brackets, all physical capabilities, things that you can implement in the COVID crisis. Yes. Okay. I'm going to start with number 10. Whilst you're self-isolating at home or you're social distancing, please look at your flooring. Find the rugs that are hidden around your house, normally under like the dining room table or the coffee table. They're useless there. They're useless, okay? Get them on the slippery floor where your dog is regularly slipping out of the back, slipping on the forward, because soft tissue, dysfunction and pain is a massive contributor to the bigger picture. Number 9.
Number 9 would be, while you're in self-isolation, do not make the mistake of taking your dog out for activity at levels that it's never seen before. You will create carnage. Be sensible and go for a sustainable, consistent exercise program. Use this opportunity where you are at home with your animal to do 2 things. 1, to get it onto a routine that you can then sustain. And 2, spend time looking at your animal. You don't see your dog during the day. Just get a sense for what is normal with your dog, both to convince you that it's actually doing something, but also because if you have a better understanding of what your dog does now, you'll be far better able to identify when it starts doing differently. In other words, when we need to potentially see it. That's sort of 9 and 8, but I'll go with 9.
You're going 9. You're going to run out if you're not careful. Number for me is work out your dog's daily allowance at the beginning of the day and then have it there and don't break from it. We're all at home. It's very easy to keep giving treats and tidbits because the cupboard's there and the eyes staring at you are there. So if you are at home and you feel that you're adding more calories to your dog's intake, stop it now. Weigh out your food at the beginning of the day. Don't break from it. Number 7.
Oh, this is going to get tougher now. So I'm going to talk about things that aren't to do with COVID-19, since we spend all our time talking about COVID-19. These will be top tips. This is what I'd like owners to do from my perspective. I would like, as you brought it up, I would like to be able to engage in a more honest and open discussion with owners about this disease. And I'd also like to, it is never a problem to bother us with questions. So please see us more as a helper in your dog's journey than as a police officer trying to patrol the health and welfare of your animal.
Yeah. And on that note, I think I was saying earlier that we'd like to see CAM turn into a super organization of people that are really passionate about this disease, that are there to answer questions, and have a monthly newsletter where we answer people's questions and people can learn from each other's questions. But just this amazing resource, a bit like Versus Arthritis, which is a human run organization that answers everything from, does apple cider vinegar work for my dog, or how much is the right amount of exercise? So stay with us, CAM followers. We've got big dreams. I sound like Donald Trump at the moment. Number 6 for me is still on the whole food thing, is that a lot of us are at home. We're quite bored. We're not bored, but we're kind of easily frustrated. Start spending a little of that frustration on doing activities with your dog. So arthritis wants to be mobile. It needs to be moving. So leaving your dog in its bed 4 or 5 hours at a time during the day is not good for it. It needs to be up. It needs to be engaging. You need to engage the brain, engage the body. So do things like wrapping up little bits of food in newspaper and hide and seeking it, using your licky mats, using your Kongs. Please stay away from some of the toys I've seen on Facebook recently. Anything that involves a slippery floor, tugging on a slippery floor, chasing on a slippery floor. No, don't do it. Just don't do it. Okay, number 5 for you.
Get an activity tracker.
Oh, yes.
Get an activity tracker for your pet. I'm unfortunately not financially vested in any of the activity tracking companies. Wish that I were. I have a rescue research dog from the States. He was involved in chemotherapy research, and there have been times, I think if we use reference range, this dog would actually would have been identified as clinically dead based on his activity level, because he lies on the couch most of the day. It's essentially, he has a heart rate, thankfully, but he's unresponsive. But actually, an activity tracker is an extremely good investment. It's not something necessarily to go at, but maybe something to get. If you're thinking about what could I get from animal, they're not particularly expensive. They're fun, and make it part of the make it a sort of a daily part of your ritual. Put the tracker on, see how the dog's doing. When you're at home, see what the dog's doing. When you're back at work, when all this is over, see what your dog's doing, and just use it and enjoy finding out more about your dog's activity patterns. From a research perspective, they're extremely helpful. They're going to become the future. We will be using these trackers not just for measuring footfalls. We'll be using them to measure blood glucose. There will be a time when these sensors will be early detectors for us as vets, and your dog will essentially signal to my cell phone that it needs to come in for a check engine light. So the future is coming. So ride the wave and enjoy the journey.
Yeah, and on that note, next week we've got Duncan Lascelles coming to us about many things OA, but also Activate, which is a company that is yes.
There you go. There you go.
On this.
Yes.
Number 4 for me. I think it will be the conversation that I had today. Please don't be scared of polypharmacy. Last couple of days, I've been doing lots of triage phone calls because we're all stuck in our practices and not able to go out. And every time I mention introducing another drug, I hear at the end of the phone. And I then spend 5 to 10 minutes coaxing and coaching the owner that actually polypharmacy is a clever use of medications working on different parts of the pain pathway or maybe the disease process to get the desired effect. Using one drug and just pushing it up and consistently having your dog on it isn't ideal. So please don't be scared of polypharmacy. Number 3.
I think that's an excellent one. I would say you should be more demanding. I hate to say this to all my veterinary colleagues, but you should be more demanding of your vet in terms of what happens after you're given a treatment. So what I mean by that is don't just walk out. If the vet tells you this is what we're doing, that's great. Put a timeline on it and reevaluate it. Make us accountable for feeding back, and for all of us as a team making a decision as to whether what we're doing is not working. And then, as you say, if necessary, multimodal treatment, a change of treatment, whether it's a dose change or a just discontinue. But if we don't do that, we're going to continue to just medicate animals where they're not responding. And that, to me, is like unnecessary surgery.
Yeah. And on an everyday basis, think about this, guys. That reassessment appointment that might cost you £30 might actually stop you using your non-steroidal on a daily basis.
Yep.
You get that money back in an instant. So don't be scared of these reassessments. Hello, David. Nice to see you this evening. You're a bit late.
Hey, David.
Number 2 for me is, again, back to the triage phone calls I've been having this week. I swear that nearly every case that isn't doing very well, there is a lifestyle component that hasn't been addressed. Let me tell you 2 stories to illustrate this point. One lady is on her dog's on multiple medication. She's been to multiple centres with multiple interventions. And after a hefty 20, 30-minute phone call, it turns out her dog is still chasing the pheasants up and down the fence. So it goes out in the garden for a wee, and before you know it, it's chasing the pheasants, and it's gone from 0 to 100 miles per hour. It's jumped up and down, it's in and out of the rose bush, and then it's back in. And no one has addressed that. No one has said, that's got to stop. I've had another one where it actually fell out of their mouth in the phone conversation that the dog bolts down the stairs when the postman comes, and it happens every single day. And he literally bowling balls down the stairs because the postman's there. Elbow OA is not going to like that at all. So be a detective. Look at your dog's lifestyle from a very practical point of view, because I bet you will find something. So please look at lifestyle. Number 1. It's got to be a good
Number 1 is a good one. Number 1 is help us do better for your pets. Two components. If you can afford to, insure your pets, because only by doing that can we deploy multimodal therapy, best in class, etc. And the second, and the thing that's particularly heartfelt for me, is please, please, please participate in research. Without you, we can't do anything. We can study everything we want in the lab, in test tubes, but we need to know what real dogs and real owners feel about the things we do, how they respond to treatments. Participate through Holly's Army, and we'll do this clinical trial if you can advocate for that. I can't recruit. We don't get a primary osteoarthritis caseload through the vet school. We see end stage. The question was asked about end stage joints. We see those. They're coming in for surgical management often. What we need is the primary care setting. We need the regular OA. Those are the cases we need to really see. So if Holly's Army and others like that can actually build networks and allow us to leverage that through multi-center trials, that would be a massive contribution that each and every one of you can make.
Well, we can do that. So Cam has got a website, and we can have a sliding bar talking about all the trials that are happening in the UK at any one point, so that people can see. So anybody that is running trials, get in touch. Our resources are quite short with regards to manpower. We can't find you. You need to find us. Get in touch and we'll do that. We'll put it across all of our Facebook platforms. So main page, CamPro, and Holly's Army. More than happy to help with that. That is such a good point.
Excellent. Okay.
Thank you. So you've already stitched yourself up because you're going to be coming back to talk about stifle.
Oh, yeah, that's okay. I don't. Can I just come back to one question that was asked here? Laura asked about whether or not there's a point at which shockwave cannot be used. We don't know the answer to that. I think that if you look at the studies from laboratory animals where rats that are treated with shockwave will actually protect their cartilage, clearly that's not going to happen if there's no cartilage. But my guess is that even with the most advanced cases, there could be some pain management, some flexibility improvements that could impact quality of life. So I'm not saying it's a cure-all, but it might be, again, as part of other therapies, a supportive approach in those cases. And again, all of this stuff has to be researched to understand and really do proper studies where we really do a proper controlled study rather than just my opinion being that I like it. I like doing it, but it has to work. Otherwise, it's just wasting your time.
No, and I think to add to that is that the body is kind of like biomechanically connected to each other, and you might be focused in treating the elbow, but think about the other joints in the locality and the other soft tissues in and around it, and maybe shockwave is used on another part of the dog's body that still helps with the actual original focus disease point. So yes, I think, shut up.
Yep.
Right. Amazing,
it's 7:55. 7:55. We need to get outside and clap for carers.
So see you later, guys. Thank you so much. And we will see you tomorrow. See you later.
Thanks, Hannah. Take care.
Bye-bye.
Bye-bye.